We have this morning Dr. Al Tamimi, who's given his lecture, which is a tie-in to this weekend's course.
Yes. So this is a continuation of a previous lecture. We did the diagnosis of sacroiliac joint. Today we'll start the treatment. So if a patient comes to you with a positive history, a positive exam, and then progressive test was positive, then the next line of treatment is start with the non-surgical treatment. Then if they fail the non-surgical treatment, then we'll go to the fusion. And the non-surgical treatment include start with the NSAID. I'm against narcotic, but if the patient needs short-term narcotic because of after trauma, then physical therapy, external support. Sometimes you can find it in Amazon. People buy it and wear it. If that didn't work, then we talked about the diagnostic injection in the past, but now it's therapeutic, where we can add the steroid, and that can help, and the radiofrequency ablation of the nerve. And if all this failed, then the next line is fusion. So first is physical therapy, and really the physical therapy is the most important, is stretching, strengthening of the muscle surrounding the joint. But again, this is also depend on the compliance of the patient. Most patients don't like to do, for example, exercise. And by doing that, it may not help the patient. Also, they need to change their activity of daily living, where if a patient is want to sit all the time or standing all the time, they need to change that. And that sometimes compliance will be difficult. The next one, if that didn't work, then injection, and all the data show that the injection is a short term. But in general, when I send the patient to a physical medicine rehab or pain management physician, most of the time injection help, and they don't come back to me for the fusion. And they can't get the injection, they get 3 to 4 months of relief. And if that becomes shorter and shorter, then the next one is radiofrequency ablation. The problem with the radiofrequency ablation is that you can see how many nerve they need to target, and also they need to target the L5, as we described in the last anatomical structure in the last lecture, and that will be also difficult for to get all these nerves when they come from the foramen. That comparing between the radiofrequency ablation and the non-radiofrequency ablation patient, and they find that there is a rapid decline in their pain, but then become back to normal after 3 or 6 months, and sometimes it can last to 12 months because of regeneration of the nerve. So the surgical treatment of SI joint is not new. The first person is Smith-Peterson in 1926. They did this big surgery. Patient complication is high. Patient need to be non-ablated for a long time. Blood loss. So that's why it's decline in the surgery, except in trauma, until really recently, where they start to use the minimally invasive approach. And by doing the minimally invasive approach, the patient can go home the next day, and just a few days of partial weight bearing and minimal blood loss. There are about 26 players for SI joint since they started with iFuse really many years ago. I think 2012 or 10. No, before that, I think 28. And then since that time, it is 26, and there are many type of screws or implant. Even nowadays, the pain management start to do it with the small implant, they do it. But really, most of the data came from iFuse. And you can use whether under fluoro or under O-arm, both of them it can use whether with all the company, that means Medtronic or Globus or iFuse, they can use just under direct fluoroscopy or O-arm. So how the setting of the patient is very important. I use more time to get the patient position before I start the surgery, and once everything is set, really take me 20 minutes, 30 minutes maximum to finish the surgery from skin to skin. But the timing is to make sure that the patient, so this is my last patient, I get approval for getting the picture for him. I took my time to position the patient. You need to put some roll under his chest, roll under the pelvis, and then I get the lateral view, inlet view, outlet view, and then after that, when I say finish, I tape the patient, make sure that there is no movement during putting the implant. And once we're done with that, then I start the surgery. And as I said, it really takes short time to finish the surgery. So we have the most important, as we said, the lateral view, where we start our surgery. Then we have the inlet view, and then the outlet view. And so with the lateral view, I make sure that the ala of the sacrum is really in one line for both the right and the left, so that you know where you are. And you can see here, you see, I think you can see there's two lines. So I make them become as like one line here. And by doing that, you're protecting, you don't go far from this line. So your starting point is somewhere here. That's where our starting point. And then before I start the patient, I mark everything and make sure that where's my implant will be. And then we have the inlet view. And by doing the inlet view is to make sure that we are not reaching to the pelvis with our implant. And doing that, the S1 foramen become like a line. And that you know that the best view you have, and to prevent any implant going inside the pelvis. And then we pass our implant with the outlet view. And doing that, we need to see the foramen, the S1 foramen. And that we can see it here. And then you put your first Jamshidi, then get the first one, then the second one. And once you start the first one, the rest will be easy. So the first implant is the most important implant. And then end with. So in the past, when we start, so we usually put it, we so worry that we are getting into the pelvis. We start our implant, put it more posterior, but we find that putting anterior is much more important. And that's the end of the surgery, small incision. This is the CT scan done for different reasons, but I find it, and one of my patients is. And you can see very important don't to reach the foramen.
I didn't know how many implants to put in. 3.
And in the beginning it was 2, but now it's 3. And I usually use iFuse. I have no interest with them or something. But the reason, because they have triangular shape. And that if you think about it, if you do that, the screws, and if you do 2, then it can move with the shape of the sacroiliac joint. But if we do 3, and I do 1, 2 posterior, 1 slightly anterior, and with the triangular shape, and they are triangular, so to prevent the movement. And most of the so when I start, I make sure the patient is partial weight bearing for a long time, but now it's shorter and shorter, unless the patient is osteoporotic, for example, or comorbidity, I make it for 3 weeks, but I can make them between, even some of the surgeons do it for 1 week. I usually do it 2 weeks to 3 weeks, partial weight bearing. And that's another thing, I don't do bilateral. And most surgeons don't do bilateral because partial weight bearing cannot do partial weight bearing for 1. And 2, sometimes even we don't need to do the other side. So most of my patients, which I did in the past, I do one side, and the milder, the one with less pain, don't need to the surgery. And I think mostly because they are start to, in the beginning, they don't know which one is hurt, and they start to do weight bearing on both sides, but now because they are better on one side and make time to heal for the other side. So most of the time I don't do the other side.
You say partial weight bearing, just they're in crutches or something?
Crutches or walker, yes. Most of the time patient want crutches. So I usually admit them to a 23-hour observation. Physical therapy comes the next day for them, and they give them either the walker or the crutches. So this is the one which I use, which is a triangular shape, and also the surface. And you can see once you mounted the implant into the SI joint, and this will get all the blood with it. And really, I don't put any allograft or autograft inside it, and they fuse solid. But you can, if you want, like a patient, for example, a severe osteoporotic, you can do allograft, but I usually don't. Now, there are other companies do different approach with posterolateral approach. This is Medtronic. They use posterolateral approach, and they use the round shape implant. So unfortunately, most of the data has came from iFuse. And this is the first study show for the first 2 years after the implant, and they found that there is about 80% improvement, more than 80% improvement in visual analog scale and disability index. And at that time, they get the approval for the device. And now, after that, they have the other study which showed about 6 years continue to have improvement. And you can see the denervation, that means the radio frequency ablation, they get good result, then they back to previous pain level.
Is response to RF ablation predictive of the longer-term response to a fusion?
No, it's the diagnostic test. That means when they inject the patient during the diagnostic, that is the one who give us a better result than the RFs.
So if they don't respond to that diagnostic block, you wouldn't.
Yeah, if it's not respond diagnostic, I usually I usually above 75 and more. There are some surgeon 50, and the data show that the higher the better. So I usually very strict when I do my surgery. And this is also show that there is improvement in narcotic use. So these are example of, I will give 2 examples of my patient, and these both of them need bilateral surgery, but as I said, most of the time is only one side that can help the patient not need the other side. It's a 45-year-old patient with 7 back surgery in the last 6 years between L5 to S1. His last surgery really by removal of the hardware, continued to have pain, and that's typical positioning make his pain is worse. And even because of the severity of the pain, he had been seeing psychologist, and he's better after visiting with the psychiatrist and the psychologist. And he tried physical therapy. All the tests was positive for him, and including exam, provocative test. And then I sent him. He had, before I saw him, he already had treatment with the sacroiliac joint. They have good results, about 80% relief with the, but only for 3 weeks. And then I sent him for 2 injection, diagnostic injection, and both of them is between 80 to 100% relief. And at that time, we did the surgery for him. And you can see, this is when he came first. This is his. First initial assessment when I saw him, and then once I did the one side, then he came after that. Is only the pain is only on the other side, and that's why I just recently did his other side. And that's his surgery. This is another lady, which is a 27-year-old, history of trauma, severe back spasm after the trauma. And she was living in Arizona. She had SI joint injection, 70% relief for 1 week. I saw her all the exam and the provocative test was positive. We did the 2 diagnostic tests for her, and both of them is about 75% reduction in pain correspond to the local anesthetic. It's only for a few hours. And so I did one side for her again, and this is her initial assessment when she came to see me at that time. And this is the second one where you can see it is only on the other side has pain. And that's when I did her the last surgery. Any question?
How frequent does this issue come up?
So for me, we see many of them, but most of the time when I send them for injection, the injection help don't need any surgery. So really, I do one every few weeks, maybe every once a month, maybe sometime every 2 months, depending upon some months I get 2 or 3, sometimes not. And I get, once you start to do it, then and the pain management and physical medicine know about it, they start to refer you. As my last patient, I didn't do her yet. I didn't even see her. That means the pain management, he did the hair injection, get good result, therapeutic, but lasts only for a few weeks. Then he did 2 diagnostic for her because they know that I want to do diagnostic. Both of them is 80 to 100% relief. He sent to me. So even I didn't see the patient before. But if you, in the past, we never examined the patient for, and I don't know how many, he had 7 surgery. This is the problem from beginning, and he has this all 7 surgery or not? I don't know. And it is in the population, it's 20%, that means.
I'm pretty far removed from this, but could you briefly take me through the evaluation of how you determine that it is the SI joint with the 14 finger test?
Sure. So if the patient comes with back pain, and as we talked before, it can be, even some patients have radicular pain. So it's similar to lower back problem, similar to hip problem, piriformis problem. So it can similar to any other surrounding area because of the refer pain. So with the exam, the patient comes with the localized pain, and he put the finger there. I said, "This is my pain." Then you examine him, and the 14 fingers. And the 14 finger is the patient. Yes, the 14 finger is the patient presentation rather than your exam. But still, you can do your exam, and you find tenderness, and then you need to rule out all other issue. Plus you do provocative test, which is fiber test, titrus test, and I'm happy to show it to you after the lecture. And then after that, you need to send the patient for lumbar spine to rule out any lumbar pathology. CT scan for the pelvis, and also not only to rule out pelvic pathology, but to see your sacroiliac joint, how it look like. That is it, because some sacroiliac joints you can see wide, and if you put the implant, it don't work. And then you do hip X-ray to rule out hip pathology. And once you get this, then you send him for injection, diagnostic injection, and with no steroid. And if it's proved to be positive, actually, the first one I send for therapeutic. If I saw the exam, I send for therapeutic. And if he had good, because most of the time it don't come back, they said they have good results. So why I send him for diagnostic, positive, and then send him for therapeutic.
I have a couple questions.
Sure.
I did the course with SI joint a long time ago when they first were on the market, and I thought that several of the people at the company were going to be indicted based on the quality of the data and the personalities of the people involved. I was proven wrong about that point, and they about SI joint fusions more generally so far. Is there any randomized data? Are there any randomized data so far?
So the most of the, I don't think they have randomized data, but I think most of the data was level 1. A few data that I said they have level 1, which they are following the patient. But again, these are sponsored by the company. But for me as independent, I usually find it is effective if you select the patient. And most of the time, the patient is not 100% relief. It's 80% relief. And those who I did for them till now, hopefully, no one complained, and they are still coming to do the other side if they need it.
The second question is, I remember from the course that like you really whacked the crap out of that. Like,
This is the only time of surgery I think I'm orthopedic.
Yeah. Have you ever had like just like a bone fracture or something? Like,
I did not, but I think it is, sometimes I think about it.
and last question is, why don't you just use the arm? Because getting those exact views on the fluoro, I mean, you might be good at it, but if you have a
So a lot of surgeons do arm. For me, it's very fast to do it with the fluoro, and if you know your landmark, really, as I said, it took me 20 minutes. That means even with the resident, 20 minutes. I think most of the resident with me. Once you get the first one, then the rest would be easy. Arm, and you need to put another incision to put your area, and then spin. And that took me a longer time, but it's not wrong if you want to do it in the arm.
Yeah, one of the surgeons I trained with in that situation where I didn't want to make another incision would just eye band the crap out of the star to the back.
Right.
And then put the balls on through the eye band.
Band.
Gives you enough for a relatively.
Yes, that's, I mean, as I said, it's not wrong. And if I need to do it one day, I will do it. But in general, I use fluoro because I'm good in it and just finish.
What's the big difference between therapeutic and diagnostic injections?
The steroid.
The steroid.
Yes. And also the therapeutic, you can put it periarticular. You don't need to go into the joint, and there is no data show whether you put in the joint or outside the joint can help. But in the diagnostic, you need to put a contrast, the amount of medicine not more than 2 cc, so that don't leak outside and give you false positive, false negative result. So usually it's more strict with the diagnostic. I usually send exactly what I want, 2 cc, including the contrast with no steroid.
I have a couple comments.
Sure.
Just building on themes that you said, because they're themes that I share in the operating room too. So just following up on the OR, I think when I do my percutaneous radiology, which I do more of it, I tell the resident, if you take the time to get a good image before you start,
right,
the rest of the surgery is really easy.
Right.
So a lot of people actually use navigation actually for percutaneous radiology because they get a 3D view and they can get right into the foramen. So I think it's all about the imaging that you're most comfortable with. But if you're going to use C-arm, take the time before you start, with any procedure to get a good view.
Correct.
I know people who've had medical malpractice cases because they just sort of rushed through it. They didn't get a really good view and ended up doing wrong level surgery because, they had the lumbarized sacrum. So, I mean, there's different, but it's a general concept that I just thought was worth emphasizing. The other concept is response to diagnostic tests. We see this in pain procedures all the time. The companies really want you to implant their devices. And
correct.
They'll really push you. And the data and the FDA always pushes the 50%. But if someone, if you tell patients you need to get better 50%, guess what? They're going to come back and say, I'm 50% better. And so I think I tell my patients, you have to have an unambiguous response, not I think it was 50%. If they say that, I don't do the SI, but for any procedure where you're using that decision maker, I think the 50% is way too low because there's so much stability.
That's a good comment, and I the same thing with the spinal cord stimulator. If the patient comes and don't take the trial from me, that that this guy will get better, but I don't know if it help or not. Let me think about it. Most of the time they don't work. So the same thing with the SI joint. That's why for me, 75 and more, even some insurance agree with 50. I don't do with 50 because I know, as we said, it is 80% improvement, and 50, I don't know how much it will become a good result or not.
Getting back to John's question about, how many people are doing this. So last year, I finished my term as the director of the board. In the last few years on the board, I was chair of the credentials committee, which means I get to see all the problems. And that's right when POST came online too. And if you guys haven't heard about that, POST is, after you've been in practice for a couple of years, you got to upload all these cases. And it's really painful for you guys because you have to upload images and case summaries. Well, it's also painful for the reviewers. You have to go through 125 cases and it takes a lot of time. But when I first started seeing some of these SI screws, I had to dive deeply, ask my colleagues, what's this all about? And it seems like some of the indications out in the community are a little sketchy.
Correct.
If the ones who reported their outcomes accurately, which you have to report at least 3-month outcomes,
Right.
that's the kind of stuff that gets flagged.
Right.
You know, because you have to pick just 5 cases that you will be examined on your cases. And if you're doing sketchy stuff and patients aren't doing well, that's a big red flag.
Yeah, I've been seeing some patient come for second opinion, but they have the fusion and then get better. And
Shocking.
I mean, and most of the time, as that I have one patient. He said never had a diagnostic test. He said
They have
that.
an SI joint.
And they have a side joint test, correct? Yeah, but which is shocking. He said I went that he has back surgery. Then he went there. They examined him. Said, "Oh, you need SI fusion." I said, "Did they do the diagnostic test for you? Did they?" No, just and he never get better. Of course, he don't get better.
What percentage of these out in the community or maybe nationwide are being done by neuro versus ortho?
I don't have that number. I don't know, but I think nowadays equal. But in the past, start with ortho, then now it's equal. But I see many neurosurgeons do it.